we're now welcoming back Hussein to discuss before lunch the retrieval process and the transplant itself. Over to you, Hussein.
Thank you, Tess. I hope this builds up your appetite. I've got some photos as well, so probably best before lunch than after lunch. And Jane, I saw that comment on the chat as well about the 15 months. And I think if I could say one thing, it would be just remain persistent, please, because it can take a long time. It may feel like things are running very, very slowly, but it is worthwhile in the end. So I was going to pick up on exactly that as well.
Oh, sorry, I beat you to it.
Beat you to it, but it really is a valid point. So I'm glad you picked up on that.
Thank you.
Okay, let me share. So as I said, I'm going to talk to you about the surgical process involved. I think I've got until 12:40 and it shouldn't take that long. So hopefully there'll be some time at the end for questions. I know other talkers have been through this before, but there are two main types of donors, deceased donors and live donors. There's two real types of deceased donors, donation after circulatory death and donation after brainstem death. And I'm not going to get into any more detail about those at all, because obviously that's not why we're here. So I will tell you slightly more about live donation, what happens actually in surgery, and the pros and cons of live donation as well. So this is a slide produced by NHSBT. NHSBT are the umbrella organisation of all transfusion and transplant services in the UK, and they produce annual data, very, very detailed data on what activity we're doing and our outcomes. And this is a graph simply to show from 2011 over 10 years, so up to this year, what our donor numbers have been like. And you can see that 2020-21 is slightly skewed, obviously because of the COVID pandemic. But in the years 19 to 20, we had about 1,000 DBD donors, about 600 DCD donors, and we've had consistently over 1,000 live donors in the UK. So living donation is a really, really important, significant part of the kidney transplant process. And it means that over 1,000 transplant recipients are not having to wait on the kidney transplant waiting list. You know, it's a huge advantage to those patients, but also to the wider waiting list, because there just aren't as many people on that. So it really, really is hugely important and a big part of the work that we do. Obviously, a live donor is not just one operation, it's two operations. So for every live donor, there's two operations, the donor and the recipient. So although it's a huge amount of work and a logistical challenge, it really, really helps, as I said, not just that recipient, but the wider waiting list. Okay. So the advantages of live donation, and I think it's very fair to say the advantages are much, much higher for the recipient than for the donor. The advantages of a live donor transplant for the recipient are, by and large, a better quality kidney. The donor, as you've heard, is very, very well worked up. There's a huge amount of assessment that goes to it. They obviously have not had an injury or an illness that has led to their demise. And they are fit and well. So the kidney tends to be of better quality. The average lifespan, and it really is average, you know, everyone is different, but the average lifespan of a kidney from a live donor is 20 to 25 years. A kidney from a deceased donor is about 10 to 20 years, that sort of timescale, more like 10 to 15 years. So you do tend to get a better quality kidney from a live donor. It tends to last longer. There is, of course, a shorter wait time, and this has already been discussed, but it normally takes 3 to 6 months if the live donor is fit and well and there's no issues. And if we go back to when recipients become eligible for transplant, if your donor is being worked up with your GFR being at 20, we would hope that we would be able to transplant you well before you go on dialysis. So the shorter wait time is one, predictable, but of course then enables us to transplant you before you need dialysis, which means that your outcomes therefore are better because you've never needed dialysis. It is a planned procedure. They happen during the day between 9 and 5. Different hospitals do them differently, and in some hospitals we'll do the donor and the recipient in parallel, so at the same time. In Manchester, we tend to do one after the other, and really the outcomes are no different, and it's just about the logistics of that hospital. But either way, the ischemic times, which is the time the kidney is out of the body, are very, very short in live donation. And that's one of the reasons why the outcomes are slightly better. In addition, if the recipient is very, very complex, then we prefer to operate during the day. If we need other teams, so vascular surgeons or other specialists involved, or specialist anaesthetists, we can plan for that. If it's a deceased donor, that integration becomes more difficult, especially if we're operating at night. Because of the advantages, there are obviously slightly lower rates of complications with live donation, especially as I've spoken about delayed graft function, which is exceptionally rare for recipients of live donor kidneys. And there's lower rates of transmission of cancer and infection, because again, the donors are worked up so thoroughly, we should find anything. Now, that's not always the case, and sometimes things are missed. So there have been episodes of transmission of cancer or infection from one to the other, but compared to deceased donation, the rates are very, very small. So overall, the recipients for the advantages for the recipients are very, very good, very high. Now you look at the list of advantages for the donor, and this is not to put donors off whatsoever, but I think we do have to be realistic about what the advantages are. And there is, of course, a psychological benefit. Almost all donors have a huge psychological benefit of donating, either because they know the person, they may be related, maybe husband or wife, or children, and psychologically it's incredibly fulfilling to donate a kidney and know that you've made that difference, whether it be altruistic or direct donation. I've put query improved quality of life, and of course, if you're donating to a stranger or even a friend or a distant family member, then as the donor, your quality of life may not improve. And hopefully you go back to the same quality of life that you had, but it's unlikely that anything will improve. In a situation where if you're donating to your children or you're donating to a husband or wife, then we find that quality of life can significantly improve. We quite often have husbands and wives donating to each other because if one is on dialysis or needing regular hospital admissions with kidney failure, it affects the other. It means that in most cases, neither of them are able to travel, neither of them can continue to live a normal life. So one donating to the other really does help the quality of life of both. I'm going to talk about the risks of live donation. And I think it's, again, important to note that most patients, the vast majority, go through without any problems at all. If that wasn't the case, then we wouldn't be doing live donors in the numbers that we are doing them. But if you go for live donation, this certainly won't be the last time that you hear of these. And when we see you face to face and we've assessed you, we'll tell you about your risks specific to yourself rather than generic. But these are sort of the generic risks of live donation. With any operation, there's a risk of bleeding. There's a risk of problems with your heart and your lungs, a risk of clots in your legs that can come up to your lungs, damages to surrounding structures, as I've mentioned with other operations, and there is a risk of significant morbidity. Okay. Now, a lot of these risks are minimized as much as possible by the assessments that we do and the care that we give you, and the preemptive measures we take to try and avoid these happening. I think it's the long-term risks that are probably more significant and worth realizing before you go forward, because the vast majority of people go through the surgery without any problem. And again, very, very few people have long-term complications, again, because of the preoperative assessments that we do and the ongoing, I call it an MOT that you have every year after donation, just to check if there is any issues. But you're at higher risk of high blood pressure, major cardiovascular events, so heart attacks and strokes. Preeclampsia is a specific condition in pregnancy where the mother's blood pressure is very high and sometimes uncontrollable. And in theory, donors are at increased risk of developing end-stage renal failure themselves. if you have 2 kidneys, there's a reason we were born with 2 kidneys and you give half your kidney away, then there is a slight increase in the risk of kidney failure and therefore needing dialysis or transplant as well. Now, whether you have a reduced life expectancy or not is still out for debate. There are some studies that suggest that certain individuals may have a reduced life expectancy, but that's a very small proportion of the live donors that we have. And again, that will be discussed with you if that is your case, and if you go forward. So in terms of the long-term outcomes of live donation, these are numbers that were published by NHSBT. They're slightly old, but they are still relevant today. So I think this is really very relevant. And this is data from 2003 to 2017 in the UK. And during this 14-year period, we performed just over 11,000 live donor transplants in the UK. This accounted for just over 69,000 live donor years. And we found that in this cohort of over 11,000 people, so there had been 75 deaths. So of the 11,000 people, 75 people have passed away in this follow-up period. And in this cohort, the causes of death, the cancers dominated. And that's not to suggest at all that live donation leads to cancer, but that where there may have been deaths from heart attacks and such within the normal population, proportionately, there aren't, because we pick the live donors to be probably fitter and better than a corresponding population. Okay, so there was only 1 death from a heart attack. No donors joined the kidney waiting list, although 1 did receive a kidney transplant from a living donor. So 1 developed the need from this cohort of just over 11,000 required transplantation. Okay. And again, just to show, it sounds morbid, but this is to encourage you really that live donors are worked up in the heart and lungs, and the other parts of the body that we look at are assessed to such an extent that donors tend not to die of the issues that face the rest of the population, such as heart attacks. So risk of heart attack and problems with blood pressure and things are really very, very small. And it is patients then dying of other medical problems unrelated to donation, okay, of which cancer predominates in society. So the operation itself, Mr. Campbell did say that it can be done a couple of ways. One is hand-assisted approach, where the hand goes into the tummy, and you can see the cuts on the left-hand picture. What we normally do is a small cut about 6 to 7 centimeters long, and the hand goes in. You then have a camera port and then another instrument port to help with dissection. And in this case, on the left, we'll be taking the left kidney out. You can see the camera and the instrument ports on the left-hand side of the tummy. And then the port that we use to put the hand in is also the port that we take the kidney out of. And other surgeons in the UK, the other predominating method of retrieval is through purely keyhole, where you may have 2 or 3 or 3 or 4 smaller cuts within the tummy. And again, this is a left kidney that we're taking out on the picture on this side, because you need a couple more ports to work, and then a camera port. And then at the end of the procedure, a smaller cut is made either lower down in the tummy in the middle or on the left-hand side, with which to take the kidney out of. And really the choice depends on surgical preference and how the surgeons have been trained. The outcomes really are very, very similar between the two, but they're the normal process. If you are the donor, then the position that this patient is lying in is what we would expect. If we're taking the left kidney, you'd lie on your right-hand side. The table is at a slight angle to try and bring the kidney up close to the surface of the skin. And it takes 2 to 3 hours. So the patients are often in this position for 2 to 3 hours. This is obviously a slightly abnormal position to be lying in. And patients do wake up and feel that they've been, some patients describe it as being hit by a bus, just because you're aching and there's pains everywhere. And these tend to be musculoskeletal by and large. It can cause back pain and make that worse, or a bit of neck pain. Although you're fully supported, it's just an abnormal position to be lying in. I can reassure you that it does get better very, very quickly within a couple of days, just while you're moving around. But it's because you're in an abnormal position that you're not used to being in. So the operation involved, I'd love to show you a video, but there's just not the time. What we want to see eventually is something like this. And this is after quite a bit of dissection, but we want to identify the two blood vessels going into the kidney, two blood vessels coming in and out of the kidney. So one going in, which is the artery, and that coming off the aorta that's along here. The aorta is the main blood vessel in your body, and the renal artery there, so carrying blood into the kidney. And then the renal vein, which is this slightly blue structure that carries blood out of the kidney. This up here is the kidney surrounded by fat. So all this yellow stuff is fat. And what we would then do is have an automatic stapler, staple across here, staple across here. So we divide the vessels, we'd leave staples in, and they'd seal up those vessels to stop any bleeding, and then take the kidney out. Obviously, you have the ureter that we can't see in this picture. The ureter is the pipe that takes urine from the kidney to the bladder, and that can be divided separately, either with a stapler or specific devices to help seal it, or clip it, just to avoid any urine leaking backwards from the bladder out. Okay, so that's what we hope to see. This is a slightly less clear because it's a picture of a screen, but occasionally about 30% of patients don't have one artery and one vein, may have more arteries and veins. And if you'll believe me, this patient had 3 arteries, so there's one there, there's one there, and there's one up here, and 2 veins, one here and one here. Now, this is something we know about because we do a lot of scans to assess the anatomy and to assess the number of vessels coming to and from the kidney. We don't like being surprised, so we were aware of this. And all it means is it's slightly harder dissection when we're taking the kidney out. But actually, the more difficult point is then putting the kidney in, because then we're making more joins in the recipient. So it can be slightly more complex. Just because you have more than one vessel or one ureter does not mean that you're not eligible. Okay, we would just like to take the most anatomically straightforward kidney for you and the recipient. So what does the recipient operation involve? I'm not going to go into too much detail with this. There's other talks as I've done where I go into slightly more detail, but I think as a donor, you obviously want to know what happens to the kidney and what we like to do and see. So you've got the 2 blood vessels coming off the kidney, and we need somewhere to put these blood vessels to. And what we do is we make a cut in the lower left or right hand side of the recipient, and we find the blood vessels going down to the legs, and we mark them with blue and red slings. So here is the artery, which carries blood down to the leg, and here is the vein, which carries blood back from the leg to the heart. And all we want to do is identify these blood vessels and then join the corresponding blood vessels from the kidney to those vessels themselves. So this is the kidney. This is one of the veins coming off the kidney, and we're joining it down to the vein that comes from the leg. And then the artery, which tends to be slightly smaller, coming again from the kidney, and that's the artery going down to the leg, carrying oxygenated blood into the kidney. You can see here the kidney is quite white. Obviously in situ, when it's got blood going round, it's quite pink or purple, but here it's white because it's had all the blood flushed out of it. And then once we've made the join, what we really like to see is that's the kidney, that's nice and pink, that's the ureter, and that's urine coming out of the ureter. Okay, in deceased donation, this is really quite rare, but in live donation, it's very, very common to see urine spurting out of the ureter. And then we know that things are going well and the kidney's working straight away. And we do often see quite a large amount of urine on the table in live donation. So what happens after the operation? Well, most donors will come back to the transplant ward. You will have a machine with you, and this is a button that the donors can press. It's called PCA, so patient-controlled anesthesia. And in here, there's a syringe of painkiller, and patients are encouraged to press the button whenever they get pain. And there's a lockout, so you can't overdose. And the lockout depends, it's normally about 5 minutes, but whenever you get pain, you can press the button to help. On the back of that, you will have things like paracetamol as well, regularly to help with the background pain. While you're on this, you tend to have a bit of oxygen. Most patients will have a catheter in, certainly for 24 hours or until the next day. And then that comes out normally on day 1. so the day after the operation, and that's really for ease rather than anything else. So you're not having to get out of bed in the evening or at night to pass urine, because we give you a lot of fluid. So all patients will have fluid going through, and we do give you a lot of fluid in theatre and after theatre to make sure that we're flushing out the other kidney and that's working as quickly as possible. And if you need it, there'll be specific monitoring of your heart and your lungs as well on the ward, although normally that does stop after recovery. Occasionally, patients have a drain put into the surgical site, and the drain is a plastic tube that drains any fluid off. It doesn't always happen, but sometimes if there's slightly more fluid, and what we're doing is we're taking a kidney out, which leaves a gap within your tummy, and then often the body just collects fluid there, and that's perfectly natural. And if we're concerned that there's going to be too much fluid there, we will leave a drain in just to help drain that fluid off and stop it becoming infected. And that drain shouldn't be in for more than a couple of days. So once you get to the ward, there'll be regular blood tests, and those blood tests will be checking your kidney function, your blood levels, whether there's any risk, any sign of infection. And what we find is some of your kidney function tests do get worse over a short period because your body needs time to adjust to having a kidney taken out. So your creatinine is a toxin in your blood that your kidney clears. And we check your creatinine, and we often see it go up in the short period after after the donor nephrectomy, and then it starts to come down and normalize. And that's perfectly normal. We do make sure that you're producing enough urine, and again, the catheter helps us do that without causing too much inconvenience to you for a short period. And we make sure that you're drinking enough. So we'll have you giving you fluids for a short time after theatre, because you can become nauseous and not want to drink too much, and we make sure that there's enough going into you. We'll check your weight to make sure you're not losing weight or we've not given you too many fluids. And at most hospitals, you'll get a daily review from the surgical team and the medical team. Most transplant units will have a combined ward round, certainly for the donors as well. There's obviously a bit of pain because you're having a cut, and the PCA normally stays on for about 24 hours, and we try and take that down as quickly as possible because it can lead to nausea, vomiting, and constipation as well. So the quicker we take that down, the better, and then start you on oral painkillers. And with the surgical approaches that we now use, pain isn't normally too much of an issue after the first 24 hours or so. Almost everywhere now you'll be seen by the MDTs, so the multidisciplinary team. So that's the surgeons, the medics, specialist nurses, the ward nurses, live donor nurses will all review you on the ward, potentially the pharmacists as well if they need to. The length of stay tends to be an average of about 4 to 7 days, and the limiting factor is just a bit of mobility. We're now trying to get patients out actually at day 3, which seems to work very, very well. And all the patients within the first week will receive a call from the live donor coordinators just to make sure that you're well. What we do is a yearly follow-up, and I said MOT. You're normally seen or assessed at about 6 weeks after your surgery, and that's again is just to make sure that everything is okay and there's no issues from a surgical point of view. And then the yearly follow-up and MOT is often done not at the transplant unit, but probably at your local kidney unit. And that will be some simple blood tests, things like blood pressure and a simple examination, again, just to make sure that there's no issues. Now that's done every year for life, and most patients will go to that for a few years. But again, if you're fit and well, then you may not find the need to go, but that's always available. Within the surgical period as well, the live donor coordinators will normally give you their phone number, and you tend to have open access to them. So if there's any issues, then it's very easy to get back in touch, but thankfully that's not often needed. In Manchester, we have started something called the ERAS program specifically for live donors. And this is really to try, it was instigated by COVID, and as difficult as COVID has been, it has led to us to become slightly more proactive in getting patients home safely more quickly. And this is part of that. So if you came to Manchester, and other units have exactly the same thing, but there's targets for every day. And we look at your daily progress, what we should be aiming for, what you should expect, and when we plan to get you home. So you can see on day 3 here, we'd expect to get you home, you'd be walking out of the ward, you're back to your normal diet and able to take your own medicines that you would be. Okay. Now these are aims and targets, and obviously if you have complications, then these are set back. But these would be the overall aims that we'd be expecting of a live donor. In the long term, it is important to have a healthy lifestyle. Most live donors tend to be fairly healthy, and I think donating gives people the extra incentive to be extra healthy, eat well, play sport, do exercise. You can go back to a completely normal life. There should be no restrictions just because you've been a donor. And if you know the recipient very well, then of course, that's an extra incentive for both of you to do that together. Okay. And I think I finished a bit early, so if there's questions, then I'm more than happy to answer them without encroaching on lunchtime.
Thank you, Hussein. Let's just have a look. There is one question about hernia and how common it is after donation, presumably for a donor asking the question here.
Yeah, 5 to 10% risk, really. If you've got a hand port, then maybe up to 10%. If you haven't got and doing fully laparoscopic, it may be slightly lower, but about 5 to 10%.
Thank you.
I think everybody is just quite stunned after that, aren't there? There's probably some people that are sitting there in silence. I mean, it's fascinating. It is fascinating, but I guess it's probably more fascinating for me because I've been through it. But
I think the important thing is to reassure that we tell you the worst as a donor, and we prepare you for the worst. And I think that's probably the right thing to do, because as we've said, the physical benefit to the donor is negligible, really. And it's a perfectly normal, healthy person having an operation that they don't need entirely for themselves. But to reassure that in the vast majority, it goes without a problem. Okay, we just want you to be aware of what you're putting yourselves through.
Yeah. I think what was fascinating there is the rising living donation. The rising numbers.
Yeah.
I mean, if I understood the graph correctly, the numbers of living donations exceed deceased.
No, so because the graph had three bars, so one was DCD, one was DBD.
Yeah,
so both deceased. So if you put them cumulatively, there's more deceased donors than live donors.
That's why I was confused, because I thought surely that can't be right. Yeah, I wasn't adding the two together. I see your point. Right.
Yeah.
Okay.
But I mean, living donors are a huge, significant part of the kidney transplant program in the UK. And I think people miss the fact that having a live donor means you're taking the burden off the deceased donor list as well.
Yeah, absolutely. Were there any questions that came up earlier on that we haven't covered off? I'm wondering.
I think Tunde answered the majority of them, looking through, yeah.
If I can point people, I know Jane's put them on the websites for more information about living donor. Please do go to them if you're interested. They're excellent, and they're really, really good. They're written by patients and specialists. They're really excellent source of information.
And NHSBT has ambassadors who they've trained to speak to patient groups and community groups, faith groups, and so on in an outreach program. So, if you're looking for someone to come and talk to a group or others, they are available through NHSBT.
What I found personally fascinating is the questions that have been coming in as a donor. These are questions I would have loved to have someone answer 8 years ago, but now I've come through the other side of it. What I will say to anyone who is considering being a donor, there is some wonderful online support groups out there that are well moderated for those who are considering live donation. And many of those kind of questions would be answered. And it was interesting, someone did ask the question, how big would their scar be? That was my personal fear. I didn't want to know about the scar. It was a case of, I'll deal with it when I'm waking up. At that time, semi-laparoscopic hand assisted was a new technique in Glasgow, and I was fortunate that the surgeon used that technique. So for someone who our biggest fear was their scar, I will wear a bikini. I'm not a body site. Due to my age and body shape, it's not my scar. Right, so break for lunch.
Thank you, Susan, for that. Yes, I think if given there are no more questions, you've obviously covered everything, Hussein, as have the previous speakers. So